So yeah, and just a little bit more on the research question and why I think it's interesting. It's a medicalized space. This is happening not in a, it's not recreational, it's not indigenous, it's not informal, it's not underground. This is being done in a neuropsychiatric, highly medicalized space because these clinical trials are carried out within a neuropsychiatric framework primarily. So, so it's interesting to see what will evolve within this new space. And just to skip to the end here, I was curious, because this is being carried out in a neuropsychiatric space, largely as kind of pharmaceutically inflected trials, do the people designing the trials view it that way? Or are they using that format because that's what we have as a route to legalization? So do they view it as a purely pharmacological endeavor, psychotherapy with a novel add-on, or both other, some new thing, some new kind of whole package, synergistic thing working together? So those are some of the things that I was curious about. And methods. So I interviewed 15 practitioners involved in designing and staffing clinical trials in psychedelic therapeutics, and that's mainly around mental health care. My interviewees had worked on trials with psilocybin, LSD, DMT, MDMA, and ketamine, and some had also been involved with field studies of ayahuasca, and all of them were either employed by or seconded to university research centers based in the UK, Europe, and the US. So I really was trying to restrict this to that emerging medicalized trial space. I used semi-scripted long-form interviews, which I recorded and then was later able to make transcripts of and analyze for accuracy. And so what did I find? So most informants, which is an anthropological term for person you talk to, so most of my interviewees, they were, of course, as you would expect, conversant in applying biomedical or neurological framings, but they could also use other lenses to talk about how psychedelics might function, which I thought was interesting, that kind of mixed fluency. And I'll get into, I have some quotes in a bit that I'll show you, which I think are interesting around that. Also, just a note on terms, I'm using psychedelic therapeutics for convenience. I know the different terms are used: psychedelic therapy, psychedelic-assisted psychotherapy. So I've just chosen one and mostly stuck with that. Also, biomedicine and biomedical. In anthropology, we tend to use this to denote Western medical practices. So it's traditional, what we would call traditional, kind of going to the doctor, standard clinical formats. So something else that kind of is linked to this multiplicity of perspectives that are being used by people staffing the trials was that some of the media hype around this can present these treatments as a sort of a magic bullet, and I didn't get that from the people that I spoke to. They viewed it as something more complex and nuanced, and there was, so in contrast to the kind of rigid and more standardized use of the pharmacological variables, so kind of the dosage, the timing of the dosage, checking heart rate, blood pressure, recording all of those quantitative or kind of numbers-based measures. There was more of a diversity of approaches to choosing and recording specific treatment elements, particularly on the kind of softer side, psychotherapy, sensory, how the room was set up, things of that nature. And so something that I, because the root of what I was interested in was how are they viewing what they're doing? They're the ones designing this treatment, so how are they thinking about it? So I talked to them about influence and rationales and how they came to choose different elements of treatment, different broader approaches to treatment. And I broke that up into 3 sections. So paradigmatic, so the wider sort of worldviews and healthcare frameworks and views about healing and how healing works that people can use to approach healthcare and treatment development, choice of sensory elements, and then psychotherapy and guide interaction. So paradigmatic. So as I said earlier, these trials are largely being carried out in a medical sciences space, but supplemented by some work by private companies and charities, of course. But but really they are structurally, they're squarely in the realm of biomedicine or Western medicine. However, the highly altered states of consciousness that they induce do set them apart from, for example, SSRIs. If you go to your GP and get an SSRI, you are given that, you go home, you take it for a while, you report back, and other similar drug treatments. And so that's, it's quite an obvious one, but it's important, I think, not to gloss over that. This is a key kind of differentiator from many other treatments. Additionally, in the West, there is a social legacy of mystical self-exploration and radical counterculture. And so you've got kind of all of this, this stuff in the culture in terms of how we have treated mental illness previously, how psychedelics have been used outside of medical sciences previously. So though it is a novel and emerging discipline, it's not a blank slate. There is baggage around this. So that's another reason why it's interesting to see how people navigate that as they are developing these new treatments. So in terms of what people did cite as influences, biomedical lineage. So this is references to previous medical research on psychedelics. Johns Hopkins was cited a lot, and also the mid-century 50s and 60s work as well. People also talked about structural shaping forces. So this is the randomized controlled trial format and economic realities as well. So these are, and I think that's really interesting as well. How do these structures that we're using to medicalize psychedelics, how do they influence what treatments come out of it? And also perceptions of indigenous tradition and influence. I think due to time, I'm not going to go through all of these, but I'll pick out a few quotes that I've included here. So one of my interviewees, so this is a principal investigator at a university, has said, "There's the way in which people have done trials in mental health problems in the past, particularly depression, that guide us. And then I had previously been at," and he named another academic institution, "and being part of the pilot study there, so that guided us. And then people from pre-prohibition times who've done this research in the 60s, who are far fewer and far between these days, but I know some of them. So we use their writings and their advice on specific elements and how to conduct this research and how to design protocols that works, but it was a mixture of all those things." And so I think a theme throughout this research was the idea of mixing or fusion of different elements, and you can see that here. You can also see this mix of the personal and the structural. So this person is talking to researchers who were involved in the 50s and 60s, and he's also referencing institutional knowledge and practice, published peer-reviewed studies. So, again, this is an interesting one that you do have that mix of both, as you do in a lot of medicine. I think psychedelics is, because this is a new and exciting thing, it may be a little bit clearer to draw out some of these elements if you do talk to people who are involved. And I think I'll skip some of these. Yeah, this is interesting. There were the people I talked to sometimes would reference their perceptions of indigenous use. I did not do a comparative study. I know a bit about sort of mestizo use and neo-ayahuasca ceremonies and things of that nature. I didn't get into that in a comparative way. I was just looking at what people perceived of indigenous use and how that was reflected in what they told me about their influences. So that was spoken of to some extent. And then again, Johns Hopkins referenced again, and I'll skip to the next section after this, but this is, again, an interesting kind of, fusion is a theme in this research, and also tensions. So this person has said that he spoke to a researcher that had been at Johns Hopkins and had used a cup and would present the medication to the participants in the cup. Now, this is common. This was, some of you probably know, has been used in some trials. A number of people mentioned this type of thing to me, different interviewees. And this person says he didn't like that idea. He's saying, if we're going to develop this as a paradigm in a Western medical context, we should make sure that we follow the rules of Western science. And I'll just skip ahead. I know we are nearly to 4. So now this is interesting because this comes onto the sensory elements, which again is a key difference between psychedelics and many other forms of treatment. There is attention given to the setting. So famous phrase, set and setting. So this person here is talking about the setting and how difficult it is to kind of isolate some of those variables. So at the end he says, this hasn't been studied under experimental conditions, it's just taken as a given. It's been done for thousands of years. So again, you see people here kind of trying to navigate which elements to pull in and what not to in treatment development. Yeah, so coming back again in more detail to choice of sensory elements, they often are taken from past research. Key elements common to a lot of trials: soft lighting, eye shades, music. Again, many of you will know this. Specific choices tended to be based on some of the Johns Hopkins protocols. MAPS protocols were mentioned or chosen per trial by staff, which again, in terms of kind of those cultural aspects of how medicine is done is really interesting. Who gets to choose elements? Who has that power? How is that negotiated? How are those choices made? Transformation of biomedical spaces. So a number of people talked about using clinical trials facilities or hospitals and transforming those into something that would, they felt, be more comfortable with, soft furnishings, soft lighting, covering up medical equipment. So again, we see people kind of being brought into traditional biomedical facilities, but those being transformed for psychedelic use, and plants being brought in. And one person said that they kind of got in trouble with an NHS trust for infection control reasons because they were bringing in kind of too many plants, too many furnishings. And I think we'll just skip to the next bit. Psychotherapy and guide interactions. Yeah, I just want to be sure to kind of note some of this. I spoke to more neuropsychiatrists, psychiatrists, and PIs than I did psychotherapists. So this is not something I was able to get into in depth, but I did speak to some psychotherapists, and they mentioned a number of approaches: psychodynamic, Jungian, CBT, attunement with a therapist, embodiment, inner healer, which I think we have a talk on elsewhere in the conference that should be really interesting. Dr. Roz Watts's ACE framework was mentioned. Flexibility, non-resistance, so not resisting negative feelings. Relevance of the body, which is really interesting in terms of, again, Western medicine's traditional treatment because of psychiatric conditions. Cartesian dualism, so this idea of kind of separating the mind as a body and the body as a machine that you kind of can take into the garage of the clinic, if you will, and work on. This was challenged in psychedelic therapeutics because the body was seen as relevant for some psychotherapists, and clearly with the sensory choices, there was relevance there as well. And then providing a container for sometimes really radical and challenging experiences. And I'll skip some of these. Just more about psychological flexibility. This one is interesting. I'll summarize. This person is talking about therapists and guides coming from different backgrounds, which is, again, really interesting because you kind of you do have more standardization on the pharmacological and the quantitative side. But here we have people, because again, this is a new developing thing, and there is not an agreed, single therapeutic tradition or school that you would draw from. So people were being brought together from a number of psychotherapeutic schools. So how does that influence treatment? Which I know that there's more study being done on that now, but certainly at that time that was something that I think needed a lot more study, how that may affect therapies that are being developed in psychedelics. And then this is just like a nice little story, I thought, that again, I think emphasizes the relevance of the body in these, for some of the people staffing the trials and developing treatments. From holotropic breath work, they took this technique of giving the participant a towel, and the guides can hold it as well. They can pull on the towel if they're having a challenging time, as this person says, to help them physically move through something. Views on efficacy mechanisms. I was really curious as to how people thought this worked. So I did talk to them about that, and the neurological themes that came up are really what you would expect. 2 minutes, okay. Neuroplasticity, default mode network, things of that nature. Other things that came up: drug as a catalyst to increase the efficacy of psychotherapy, perspective shifts, and feelings of connectedness. So again, kind of themes that are out there. But it was interesting that all of that came up. Again, it was not kind of slanted hugely towards one thing or the other. People initially talked about the neurological side, but then often would switch to how that influenced the shift in perspective and how that influenced psychotherapy. So we can see this sort of, ecological bundle, if you will, of elements working together. And I'm almost out of time, so I'm just going to go ahead and skip to the end. That's some quotes from people I talked to about the neurological side. Dimensions of relationality, I'm not going to cover this now, and wouldn't if I'd had time, but I wanted to include this. This is something that kind of came out that I wasn't able to fully develop in the research, but that I'm really interested in, which is dimensions of relationality. So how psychedelics can point us towards relationality in all of these ways, but also how within psychedelic therapeutics, but also how that may link more widely to maybe how we can improve treatments in other forms of healthcare as well, because everything is relational. Everything happens in society and culture. Everybody brings their own set to whatever the setting is, whether that is psychedelic in nature or not, in terms of treatment type. So discussion and implications. As I said, medical research does not take place outside of culture. So that's why I think it is useful for disciplines like anthropology, sociology to provide that qualitative work and really get a flavor for what is happening in the medical culture around psychedelics. Biomedical synchronies and tensions. So there were some things that were very in tune with biomedicine, the RCT format, but also that provided some, that posed some challenges as well in terms of what people were able to do. And choice of sensory and psychotherapeutic elements, as I say, were not yet standardized. So this is still an area where, it is still in development, it's still evolving. And final bit. So I think that the complexity of the treatments in psychedelic therapeutics can help to unsettle this strict mind-body divide that is still prominent in standard biomedicine. And I think relationality could be shown to be a key mediator of that. How do we relate to the self, to the treatment, to the guide, to the therapist, to the molecule as well. And finally, I think a greater understanding of complexity and relationality in psychedelic therapeutics may yield insights applicable elsewhere in healthcare. And that's it. Thank you.